and people will keep on coming in. So welcome everyone to 2024 already. This is the early 2024 South edition of Delaware Mini Medical School. You'll see we have a number of different social media badges down here, including for the Sussex County Health Coalition. And there's their website right there. And Christy will tell you a little bit more about them here in a minute. So the program was started by the Academy of Medicine, which has been in existence since 1930. So we're 94 years old now. Not me, the Academy. MiniMed's been running since 2009. This year, Sussex County Health Coalition is partnering us with us on a number of the MiniMed sessions. And obviously I need to update this, but the 2024 semesters are all offered as part of the Delaware Health Force Initiative, which the Academy DPHA runs. This is with ARPA money, the American Rescue Plan Act, which is attempting to get the country back on its feet after the pandemic. There are no tests or grade in this class. The session is 1 to 2 sessions that will occur between now and the end of the year. Interested students can attend additional series, and I know that there are some students who are in here for their 3rd or 4th series, and that's fantastic. Just to get it out of the way, there is no continuing medical education or continuing education involved with these series. So if you're a professional and you're hoping you would get CE or CME, I'm afraid this is not the right place for you. Participants who attend all 6 sessions live will receive a certificate of achievement. Now, we have heard in previous classes, since most of you are in middle school, high school, or undergrads, we've heard from you that sometimes life comes up. So I'm going to send out instructions to everybody. If you miss a class, you'll need to send me an email proactively letting me know that you missed, and then you will be allowed to go ahead and watch the class that you missed and answer a couple of short questions about what you learned. So we're saying there's no grades, there are no tests, but that's only if you're attending all of them live. Anyway, the program goals, we want to enhance health literacy in our community. In other words, you understanding about medicine, about dentistry, about public health, about how your body works, and for you all about, maybe you'd like to pursue a career in the health sciences. Middle, junior, and high school and undergrad students are a primary focus. However, adults are certainly welcome. And if you are the mothers and fathers of students who are attending with you, kudos for that. That's awesome. This is a safe space to engage in a dialogue between students and instructors, but we have to remind you, you can't talk or ask about personal health issues. And we do filter all the questions through the Q&A. And we ask our presenters, as I am right now, to please let all the questions hold till the end. And then Christy and I will go through them and we will pass them on to you. Housekeeping tips. This is a Zoom webinar, not a new Zoom meeting, so you cannot see each other. Sorry about that. You should only use the Q&A feature to ask your questions. Already said, no questions of a personal or family nature. There are violation of privacy rights that we're always very concerned about. All of the questions will be addressed. Many by staff, that would be myself and Christy and others, depending on the meeting, and then others by the presenter, him or herself. You do need to stay through the entire presentation, but you can leave when the Q&A starts if you'd like. I will say that the Q&A often is the best part of the class. At this point, I'm going to turn it over to my colleague, Christy Handley, and she's going to tell you a little bit about the Sussex County Health Coalition and introduce this evening's speaker. Thanks.
Great, thanks, Tim. Appreciate the introduction. And we really are appreciative of the Delaware Academy of Medicine for partnering with Sussex County Health Coalition for this series. The mission for the Sussex County Health Coalition is that we engage entire communities in collaborative family-focused efforts to improve the health of children and youth and families all throughout our communities. How do we build our collaboration? We do this by raising community awareness of community health issues. We give a voice to our community through their concerns and ideas. We expand and publicize the knowledge base on community health promotion. We proactively engage people and organizations from all areas in the community health promotion, not just one or two, but all areas of community health. We facilitate development of child and family health promotion strategies. We develop and mobilize community resources for community health promotion. We also have been doing work in workforce development, especially in healthcare. We're building community capacity for policy and program development. We're supporting collaborative efforts to improve all community policies, programs, and practices. And we evaluate everything that we do and report out on our impact of our actions. Next slide.
Yep, sorry about that.
Okay.
There we go.
A little bit about the Delaware Youth Medical Academy. As Tim had spoken before, it is for middle, junior, and high school students only. And basically, you're getting recognition for attending the mini medical school sessions. So every session that you attend, you obtain a point or so many points for each session. And those sessions turn into badges. And so if you attend all 6 sessions, like Tim had told you previously, then you get your signed mailed certificate, which gives you the opportunity to join the Delaware Youth Academy at the level 1. Tim just told me tonight that we did just get our first 2 level 2 scholars. So they have attended 12 to 17 sessions, which comes with some things like bling and some complimentary student memberships. And then as we keep going on, you get invited to specific meetings where you get to network and you get to be in the room with some of our speakers that you will have heard throughout all of the series. Oh, and then there's a reflection paper required to move on through the different levels. I always forget that part, Tim.
That's all right.
It's okay. So this is our spring semester. This is what all of you would have signed up for. So tonight we are happy to have Dr. Haresh Sampathkumar. I hope I said that correctly. He's going to talk to us about the history of rehabilitation medicine. Then next week we have Dr. Justin Connor, who many of my Kent County youth know, Broken Bones and Then Some, the life of a pediatric orthopedic surgeon. February 20th, we have Felicia Connor, who is going to be talking to us about tackling head injuries and concussions, the diverse life of a neuropsychologist. The 27th, we have Nicholas Conti, who is going to be talking about your dental degree. And then on March 5th, we have a genetic counselor who's going to be talking to you about genetic counseling, what that looks like, what it is. And our last one will be with Jordan Weissman from AmeriHealth Caritas. He's going to talk to us about managed care behavioral health interventions. So this evening, we are pleased and excited to have Dr. Haresh Sampathkumar, who is the medical director at Delaware Neuro Rehab in Dover, Delaware. He has a subspecialty training in brain injury medicine. He treats the entire spectrum of severity of brain injuries from concussions to coma. And due to the complex physical, cognitive, social, and behavioral issues resulting from brain injuries, he uses a coordinated interdisciplinary team approach by collaborating with a group of therapy professionals, some that we've actually talked to on these series before. Physical therapists, occupational therapists, speech language pathologists, neuropsychologists, and prescribing medications and performing injections for pain and spasticity relief. That is such a really hard word. I'm going to need a speech language pathologist there soon. Some of those injections that we talked about include, but aren't limited to, Botox, nerve blocks, and baclofen pump managements. I do know what those are. I am going to let Dr. Sampathkumar talk about his education himself when he gets into his presentation. I will let you know that he's a co-founder of JH Rehabilitation, which is a comprehensive rehabilitation center in India. It offers services for individuals with brain injuries and other neurological conditions. He's a board member of the Brain Injury Association of Delaware, which is near and dear to my heart, as I used to be their executive director. And aside from raising awareness about brain injuries in the community, he's interested in improving the standard of care for patients with acquired brain injuries by collaborating with private governmental organizations and colleagues in healthcare. He is particularly interested in empowering individuals with acquired brain injuries to control and direct their own life by independently participating in activities, including education and meaningful employment. So we're going to give a great big hand of applause and a big thank you to Dr. Sampathkumar, and I'm going to turn it over to you.
Okay, and I've stopped sharing and the screen is yours, sir.
Awesome. Thank you, everybody. Thank you, Christy, and thank you, Mr. Gibbs. And thank you, Delaware Academy of Medicine, for inviting me and giving me this opportunity to present on this topic that is very dear to my heart. And let me start by sharing the screen. And also thank you for all the attendees for joining in at 6:30 p.m. on a weekday. So see that there are a lot of people here. It's amazing that there are a lot of people that are interested in healthcare. We definitely need that. So I hope that I can also convince you some more that this is this field that you should choose. How do I do full screen? You are able to see my screen now, correct?
Correct. We can see your screen in the PowerPoint like version.
Okay, but you don't see that as a full screen. It's just
No, we just see I think if you hit slideshow at the top, maybe top right. Sorry.
Yep.
Keep going all the way to the right. Like keep going all the way over.
oh yes, I see.
Yeah. There you go.
Thank you. All right, so so the title, I know the title looks a little bit different, which is History of Brain Injury Medicine is the title that I have here. The title that I think was mentioned previously was Rehabilitation Medicine. There isn't too much of a difference, but I think once we jump into the presentation, you will see what that is. And also, I'm gonna just speak a little bit before we jump into this presentation. So first, I want to say a few things. So who am I? Again, I'm Haresh Sampathkumar. I am a physiatrist that is a physical medicine and rehabilitation doctor with subspecialization in brain injury medicine. And as Christy had mentioned earlier, I do treat a wide, wide range of individuals with brain injuries, starting from mild concussions all the way to one extreme, which is when individuals are in coma or vegetative state. And the primary goal in treating these individuals with acquired brain injuries, that's not just because of trauma, it could be because of strokes and brain tumors, and there could be various reasons one would have an insult to their brain infections, et cetera, et cetera. A decreased blood supply to the brain bleed, all of those things. And our ultimate goal is basically to help them be as independent as possible, get them back to their previous level of function, if not, get them back to the level of function that we potentially could, and still, to the extent possible, helping them to be independent, right? And then that's very crucial for one's physical and mental well-being. So that's what we do or primarily focus on, and the way it's achieved is, again, as partly mentioned during my introduction, the way it's achieved is, from my standpoint, I will prescribe medications for my patients, just like any doctors, or there's certain types of injections that we can do depending on the type of complications that they have. and also, ordering labs or ordering MRIs, scans, imaging, all those types of things, depending on what's happening with them. But the other main crucial thing from a treatment standpoint is we deal with a lot of therapies. These individuals, particularly with these complex neurological conditions, they need a lot of therapies: physical therapy, occupational therapy, speech therapy, counseling. They need that integrated approach because, as some of you all may know, anything, your brain controls pretty much all of your body, and depending on the area of the brain that is affected from either a trauma, stroke, etc., various functions could be affected. One swallow could be affected, one speech could be affected, they may have paralysis on one side of the body and they cannot move. Their thinking could be affected, their cognition could be affected. So it could cause a multitude, bowel issues, bladder issues. It could cause a multitude of problems depending on the area of the brain that is affected. And so that is the reason you would need a comprehensive interdisciplinary approach to treat these individuals. And oftentimes it takes a very long time for them to recover because of the nature of the beast. So that that's something that I wanted to mention as well, and also just a little bit about what type of setting that I practice, where I practice, things of that nature. So I primarily work in a clinic or outpatient setting. So that is dealing with these individuals after they have had a stroke and whatnot. They've been in the hospital for a certain period of time, and they have done even some inpatient rehabilitation. They've been at a rehabilitation facility after they've been in the hospital. And usually these individuals are there anywhere between a short stay, could be a week, and then sometimes it might even take 2-3 months. So that's usually the time frame. And then they get discharged, they go home, and then that's when I get to see them, right? So that's in that continuum of care where I see them. In the past, up until a year or two ago, I also used to see them in the ICU settings or in the hospital settings, sometimes the emergency, and then also I would see them in their inpatient rehabilitation setting when they're doing rehab by staying at a place at an inpatient facility. I would see them in all of those settings as well, but currently my focus has just been in the outpatient setting, and that's the lifestyle that I've chosen for now. But these are the various settings. Someone in my specialization could potentially work in, and I used to also work in all these settings, but this is where I currently practice, which is in the outpatient setting. And our practice basically consists of myself, a nurse practitioner, and also a bunch of these other disciplines that I had talked about. We also have physical therapists, occupational therapists, speech therapists. We have psychologists that work with us, neuropsychologists. So it's a very comprehensive interdisciplinary practice, again, because primarily we treat individuals with lots of acquired brain injuries. We do also treat individuals with other neurological conditions as well. That is spinal cord injuries as well, but not as much as brain injuries. And so basically our primary focus is neurological rehabilitation. So that's kind of just to give you an overview of myself and kind of how our practice is set up and things of that nature. And we are in Dover, and we also have a small office in Wilmington at this time. So that's that. Now, I do want to share a few other things, which is how did I get here? What's been my journey, that kind of stuff. So basically, so I'm originally from India. I lived there until I was 23, 24. basically until I had completed my medical school and subsequent to mandatory training that's part of medical school. Now, I chose to be a doctor because my mother is actually a physician. She is a OBGYN. She still practices in India. And my father is a veterinarian. And both of them in the field that they were in. It really was something that just sort of made sense. I will say that it was really during the last couple of years of my high school that, or maybe even, particularly the last year or two is when I decided that this is the path that I want to pursue. Until then, I was really not clear. Even then, it was more of, well, it makes sense. I know this field. I have parents that could guide me, things of that nature. It just seemed to make sense. Or yeah, so that was the reason. So going into this field, I will say that I wasn't as passionate, and this is what I wanted to do. I knew this all along. None of that actually. So, but that's okay, and that is okay. And so from that point on, so the medical system in India is a little bit different. In India is different, where they follow the British system, where after medical school, after high school, one would go into medical school directly. So there is no, college or undergraduation. Medical school is not, like a master's degree or something. So it's basically right after high school. If you decide that you want to go into medicine, you would go into medical school. And also the training is a little bit different. It's usually about 5.5 to 6 years is how long medical school is, as opposed to 4 years of college and 4 years of med school, which is pretty common in the US. And I think there are some schools that do offer the 6-year program, but that's in the United States. But but that is the norm where I went to med school. So that's kind of how. So that's kind of the story of how I got into sort of med school, and so 5.5, 6 years later. So it was actually, so yeah, so so let me kind of back up a little bit. So it was actually while I was in medical school that, the next thing I wanted to mention is, how did I choose the specialty that I'm currently in, which is, first I chose the field of rehabilitation, and then I chose to specialize in brain injury medicine or brain injury rehabilitation. But the first specialty, which is field of rehabilitation. So this was when I was in medical school that I decided that, okay, I wanted to make decisions on my own, which I had not done. Again, going to med school was not something that I was very conscious about, as I mentioned. But it was in medical school I decided that I'm going to be making all the decisions for myself, and I was very particular and thinking about what are the specialties that really motivate me or interest me. What am I passionate about? Things of that nature. And when I was in medical school, I had a injury playing soccer, and I had an ACL tear, and I had to go through surgery and subsequent repair, and followed by many months of rehab, many months of physical therapy. And it was actually, and I never realized that I would have to go through such extensive physical therapy to be able to go back to playing soccer again. So that was, that's something that I really enjoy doing. And the surgeon I only saw maybe once or twice, but it was really the physical therapist that I had seen subsequently who really motivated me. And I would say that if it wasn't for the physical therapist, I would not have gone back to playing soccer for sure, and also really wouldn't have developed such interest. And it was really the rapport that he established with me, and how good he was in explaining things to me, that really interested me. And then the other aspect is also that a year later, I actually injured my other knee and tore my other ACL, and I had to go through surgery and rehabilitation as well. But even before that, I had decided, okay, something along these lines is what I wanted to pursue, and I was looking into, okay, well, how do I'm already studying medicine. How do I, go into this field of rehabilitation? So I had done some research into what are, are there fields like this that exist? Could things of that nature. And also, I had looked into. I really wanted to do sports medicine at that time. Sports medicine, sports rehabilitation is what I was really interested in at that time, and I had came across this field of rehabilitation medicine, which was not popular in India, and not then, maybe a little bit better now. It was quite well known in the United States, and I decided that I was going to come here and pursue that field. And so I did. I graduated from medical school, and I had so with so if whether you do your medical school in India or I mean whether you do your medical school in the United States or anywhere else in the world, if you are interested in pursuing medicine in the United States, then everyone would have to go through a certain tests. These tests are common for everybody. Those are called USMLEs, or United States Medical Licensing Examinations, and there are multiple steps. A lot of changes have been made, but there are quite a few steps one would have to go through. So I completed all of that, and I then did my training. First, just a year of basic training. That was in Rochester, New York. So I went from, sort of a desert climate to the coldest place on earth. At least that's how I felt. But it was good. And subsequently, I did my training in the field of rehabilitation or rehabilitation medicine in New York City, Upper East Side, East Harlem, that area, and then I did my fellowship, which is again subspecialty training in brain injury medicine or brain injury rehabilitation. That was in Houston, Texas. So that's, and then after that, I had moved to India for a year because I wanted to create, or I wanted to, I would say, I don't know if create is the word, but I wanted to establish, that's the word I was looking for. I wanted to establish a rehabilitation center in India, particularly focusing on individuals with neurological rehabilitation. And I had done that for a year, and then I moved to the United States to start working. And when I moved back to the United States after that 1 year of living in India, I had moved to Delaware. So since then, since about 2018, I've been living in actually not 2019. Since mid 2019, I've been living in Delaware. And yeah, so that's a little bit of my background, and where I am and how I got to where I am now. And just a little bit of what does a physiatrist, what does a rehabilitation medicine doctor do? So basically, so the field of physical medicine and rehabilitation, otherwise called rehabilitation medicine, are a physiatrist. It's not psychiatrist, not physical therapist. It's physiatrist. PHYSIATRIST, physiatrist. So what does a rehab doctor or a physiatrist, what do we treat overall? What does a general physiatrist treat? So basically, again, it's rehabilitation, right? That's what we specialize in. So rehabilitation, the field of rehabilitation is broad. So one could specialize in sports rehabilitation. One could specialize in pain, management, pain, the field of pain, right? Pediatric rehabilitation is another field. So where you're, treating individuals with cerebral palsy or spina bifida, or so basically, there are a lot of pediatric conditions that need rehabilitation. Neurological rehabilitation, we can kind of split that into spinal cord injury and brain injuries. And of course, I decided to specialize in the neurological aspect, particularly the brain injuries. Interestingly, even though I got into the field of rehabilitation thinking I was going to specialize in sports rehabilitation, I changed my mind because I realized how difficult it was, and how challenging it was, taking care of individuals who have had such complex issues and being able to make a difference in their lives. That was very rewarding, even though the difference might seem small compared to all the other fields where you can, where you've cured them completely and whatnot. But that does matter, and that just interested me. The fact that even that little bit of a difference makes a big difference for them, and the fact that it was challenging, but yet once a difference is made, it was quite satisfying. So that's so that's how I switched my position from one to the other. And so on that topic, I just wanted to also mention, so one of the things that also to keep in mind, when you're thinking about a field, particularly in the field of medicine, you could become, you could go into a certain sort of end field through various different fields. For example, if you want to be, let's say, a sports medicine doctor or something, right? So you could go that route either by becoming a pediatrician, and then you could further subspecialize in the sports medicine, or you could be a general practitioner and then subspecialize in sports medicine, or you could be a physiatrist or a rehab doc and then subspecialize in sports medicine. Even though they may all have different backgrounds, that's sufficient to. So these fields converge. So I think that's the point that I'm trying to make. So, for example, brain injury medicine. So one could specialize in neurology and then further subspecialize in brain injury medicine, or one could specialize in physiatry or rehabilitation and then subspecialize in brain injury medicine. Or one could, if someone wants to be a spine surgeon, they could become an orthopedic surgeon, then become a spine surgeon, or they could become a neurosurgeon and then subspecialize or focus on just spine surgery. So there are various ways to kind of come to an end specialty through a different specialty. So that's something that I wanted to emphasize, which I think oftentimes people are not aware. Okay, all right. I know I spoke a lot. So that's pretty much what I wanted to say before we kind of jump into the presentation aspect. I do want to just pause here and I want to confirm now. I know the presentation is until 8 now. How much time do we have for questions? How much time is usually allotted for questions?
So we usually like to give at least 15-20 minutes. So we usually end about what, 7:45, 7:40, 7:45, so we can leave some time for Q&A.
Okay, got it. All right. So I'm probably not going to take that long. So I just wanted to, okay, that's good to know.
If you end sooner, that's fine. Don't worry about it.
Yeah. Thank you. I appreciate it. All right. So the topic for today is history of brain injury medicine. You could also make this topic history of rehabilitation medicine. It's just a subspecialization, so it really doesn't make a big difference in the big scheme of things. But the purpose is very simple, which is it's very important, regardless of at least from my perspective, it's very important, regardless of the field that you choose. It's very important that you understand the history as a whole of that particular field. I would even make an even bigger argument. It's not just applicable. This concept is not just applicable to medicine. This concept is applicable to pretty much anything, any field that one chooses. But I'll just speak on the medicine aspect for now. The reason being, it's very important to understand what has been the past and what things led to what events. And knowing that is crucial if you want to make a difference, you want to understand this as, this feel better because you want to make a difference or you want to change something. It's really important to understand what has been done in the past. So you understand, if the past is being continued, then what the future is going to hold, because you already have seen. Or you might decide, well, if this is what happened in the past because of this, then we would want to change it because we want the future to look like this, right? So to make a change in the future, you have to understand the past. So the good, medical analogy is that when a person comes to you, you always start with history, right? You get a very good history. And you get a good history to understand what is going on with them to be able to treat them. So that's the best analogy that I have. So that's really the main purpose, because the actual presentation itself will have a lot of technical details and names and things of that nature, which might not be as relevant. Again, the purpose is primarily just to show what sort of I had done for my own understanding to see how we came to where we are. And sometimes that is also not just to change. Sometimes it's also inspiring to understand and as well. So that's the primary goal. Okay, so with that being said, let's jump right in. I have nothing to disclose, at least in regards to the topic that we're currently presenting today. So I'm starting with 18th and 19th century. Certainly we can trace back and go all the way to first, second century, or even BC, from the Greeks and Rome and civilization and all that. But I think sort of starting with the Industrial Revolution, the birth of modern medicine, right? So that's kind of where we're starting. So in the late 18th century, Galvani and Volta, they had understood the role of electricity in nerves. So I'm sure those names sound somewhat familiar to some of you. And then in 1875, Richard Catton had understood the electrical phenomena of cerebral hemisphere in animals, and Camillo Golgi in the 1890s used a stain to reveal the intricate structures of a single neuron. And in the 1890s, also Golgi's stain then helped Santiago Ramon Cajal led to the formation of neuron doctrine. I'm going to be butchering a lot of the names, by the way. So if you are, if some of you are already familiar with how to pronounce these names, I do want to say that I do apologize in advance. So Golgi stain helped Santiago Ramon Cajal to help form the neuron doctrine. Again, Golgi may have heard of Golgi apparatus and things of that nature within a cell, right? So it's the same Golgi. And then also to even get there, they had to, invent microscope, right? To even study neurons and then come up with neuron doctrine, right? So that's there too. And then late 19th century, Helmholtz, Peter Mueller, Emile Dubois, Raymond, they all, identified the electrical excitability of neurons that also affected adjacent neurons, how the electrical impulses can be transmitted through the neurons and things of that nature. And again, in the late 19th century, Paul Broca and Carl Wernicke, they identified that there are certain areas in the brain are responsible for certain function. So if you are familiar with some basic neurology, you may have heard of Broca's areas, Wernicke's areas, and things of that nature in the brain. And these are named after the scientists who invented or came up with the principle that there are certain areas of the brain that actually control certain areas of the body, which again was unknown prior to that. And they were the first one to say that it's actually it's certain areas of the brain control certain areas of the body. They were much more sort of broad, and they just basically said, oh, this controls this, but it's not as sort of simplistic as that. But I think it at least helped lay the foundation that these areas are in the brain and that they are, they're particular. And then also there were case reports on, how to treat these individuals, how to do therapy. So again, Broca came up with a certain type of therapy modality on how to do therapy for this problem. And also Franz is another scientist who had also come up with his own sort of rehabilitation model to sort of treat these individuals. Again, wasn't widely successful, but at least they made an attempt. Brodmann in 1909, he was the first. So Brodmann was a neurosurgeon. He was the first to map the brain successfully. So once Broca and Wernicke came up with the basic principle, look, there are areas in the brain that controls areas in the body. So then Brodmann basically mapped out almost all of the brain that he possibly could. And this was a huge achievement because as big of an achievement as Broca's and Wernicke's and even identifying that this is even a possibility, because he basically mapped, this was again more than 100 years ago, right? And using whatever technology was available at that time, he was actually able to map the brain completely and say, okay, this is the motor cortex, this is the sensory cortex, this is where all the sensation is being perceived, and this is how you know that you're feeling the pain. This is the motor cortex. This is the area where your head is your arm is represented here. If this area gets affected, then your arm is going to be paralyzed. If this area gets affected, your leg is going to be paralyzed, so forth and so on. right? So he really mapped out the brain very well. And that map, Brodmann's map, is still being used, quite widely. I mean, yes, there are a lot of things that have come up, but it wasn't that they had to replace what sort of Brodmann had achieved. Rather, they had, they're sort of building on top of it, so to speak. So that's key. So that's quite an achievement. And then also, again, mid 20th century, right? A few other scientists established the field of neuroscience. Again, once Brodmann mapped it out, they said, okay, well, I think we need to study this more. So that was that. And then, so those were basically what I had mentioned earlier. Those were basically some of the scientific advancements that, kind of led to some of these sort of basic principles and understanding of the brain and some basic rehabilitation, et cetera, et cetera. Now, World War One, so there wasn't any major wars post Napoleon Wars in the 1850s, is it? If my history serves correct. But post Napoleonic War and World War One, right? I think there's a good 50, 60, 70 years. There wasn't any major wars. And then World War One, which is a big war again, because hence the name World War One. There were a lot of casualties, and a lot of the countries wanted to get their soldiers either back in the battlefield or get them better so they can go back and live their life. Because they're young, and they don't want them to just be bedridden and not be happy, right? So they started working on, okay, how do we best rehabilitate them? How do we best treat them so they can get back to doing things that they like doing, or even get back to war, even things of that nature. So that's when people started thinking about, again, one would get various injuries, right? They may have amputation from the war, or you may get brain injuries or spinal cord injuries. So various types of orthopedic and neurological conditions may happen. So Kurt Goldstein was one of the pioneers that had come up with some more rehabilitation strategies on top of Paul Broca on France, and his technique of rehabilitation was a little bit different than what his predecessors had come up with. And then in 20s and 30s, there was also a Vocational Rehabilitation Act in the 1920s. And that one is basically, an act. I think for the first time, there was a law that was passed, which actually, again, as you can see on the slide, it wasn't just, they were providing money to live on. Rather, it was training, again, injured veterans as preparation for new jobs, matching their new abilities. All right, so kind of what I had mentioned earlier. So this is post-war. So there was actually, so not just people trying to kind of figure this out on their own without any kind of government help, but also government played a role in the 1920 with the 1920 Vocational Rehabilitation Act, where they didn't just give money, but also had created policies such that injured veterans could be trained and be prepared for jobs that matches their new ability, right? So, for example, if a farmer had an amputation, single leg amputation, double leg amputation, they can go back to doing what they were doing. So, okay, well, what abilities do they have? What background? What is their education? And what is their interest? And what kind of training could we provide to get them into, a certain type of job. Maybe now they want to be a painter, so forth and so on. So that's that. And then again, 1935, there was Social Security Act, and then 1938, this was the first sort of association that was formed, American Physical Therapy Physicians, kind of related to the field of rehabilitation. And again, World War II, even bigger war, right? So there were a lot more people now working on basically, from an individual standpoint, as well as from a, government standpoint, government also, coming up with, again, in the 1943, you can see the Barden-Lafayette Act, which enabled new programs for inpatient rehabilitation for active duty soldiers, disabled veterans, and civilians. So basically, government also trying to encourage rehabilitation, getting them better, inpatient, outpatient, things of that nature. And then also there were, scientists, physicians, doctors, therapists trying to figure out, okay, how do we rehabilitate them? What are the principles of rehabilitation? How will they get better? What is the science behind this types of, this rehabilitation? Because, prior to rehabilitation, treatment basically involves convalescence. They would literally just bed rest and become weaker and weaker and weaker. It would take, what is the treatment? Bed rest, right? So that was a very common treatment for everything, right? Which is the exact opposite now. In terms of we realized how bad it is, how bad bed rest can be. So, combination of, again, different individuals, organizations, even also hospitals that allowed training programs to be created to train people. Right. Initially, it was people from various disciplines, orthopedic surgeons, neurosurgeons, who were interested in the field of rehabilitation. Basically, they didn't do any surgeries. They just focused on rehabilitating, getting them better. Using methods and principles that science could offer at that time. And then they decided, okay, well, we need a separate field where physicians are just focusing on the field of rehabilitation. We want to train them in the field of rehabilitation, and that's all they're going to do. So basically, various physicians from various fields who are interested in the field of rehabilitation and practicing rehabilitation decided, okay, they were going to. And by the way, this is how oftentimes a new field gets created. Any new field for that matter, this is how it gets created. By the way, so there's training programs were created, and as you can see, 1947, Frank Cruson initiated a training program at Mayo. This was the first sort of physical medicine rehabilitation training program in the country at Mayo Clinic. And people had established rehabilitation programs in army hospitals, regular hospitals, and then government also encouraging these things with various acts and providing funding for these things. And also there were, again, a lot of private funding, private interests as well that also promoted this at the same time. So again, it's starting to gain some traction at this point during World War, and same thing after World War II as well. Now, the field has been established, American Board of Physical Medicine and Rehabilitation in 1947, 1950. They renamed it. Hospitals were being built, rehabilitation hospitals were being built. NYU, Kessler, Rusk Rehabilitation, Kaiser, that's in California. So all those hospitals that were established are still in existence, and some of the best rehabilitation hospitals that do currently exist. And also, again, one more in 1947 Hill-Burton Act, again another governmental act or law that provided construction grants and loans to build hospitals where they were needed, and where it was considered to be sustainable. So it's a combination of things again, and all kind of developing at the same time. new people being trained, new specialty being formed, different hospitals are being started, funding is coming from the government and from private, all of that. And then this continues to expand now, 50s, 60s, 70s, this continues to expand a lot more. Again, the research is also developing, improving now. They came up with a mandatory helmet use, right, in the 1950s. They realized that could significantly decrease mortality and morbidity, particularly related to head injuries. And then in 1960s, intracranial pressure monitoring, which made a big difference in terms of caring for these individuals, because now you can monitor the pressure in the brain, and if something were if something was not going right, then you could intervene or not intervene. So you just had better understanding as to what was going on. And then there was research going on to better understand what's happening particularly with the traumatic brain injury. Better understanding the pathophysiology, so we could better treat it. Also, imaging was invented in the 70s, CTs in the 80s, MRIs. And also various different scales were invented. Glasgow Coma Scale in 1974, in the late 1970s, Glasgow Outcome Scale. So again, a lot of sort of medical basic science research, which was informing the field of medicine, particularly in this case, field of rehabilitation, particularly brain injury rehabilitation, and individuals were living longer, right? Because there is better management of, acute care, because you can now monitor blood pressure, you can do CT of the brain, what's going on with the brain, you have different scales. So again, a lot of these advancements also help them to live longer, which means they're going to have more people are living longer, especially with these conditions, they're going to have a lot more disability. So the field of rehabilitation also needed to kind of catch up to meet the demand. You've got a lot more people now, and a lot more people that are surviving because of advancements in neurosurgery and ICU and all that. And then, you would have to meet the demand, because now you would have a lot more complex patients to treat. Because they're not just dying right away; they're living. And how do you treat them? How do you get them back? How do you give them the quality of life? So again, a lot more. This whole slide just consists of various Rehabilitation Act, Social Security, Medicare, Medicaid. All of those, played a role on the way the field was being shaped. How the people who are interested in this field were being trained, because the funding for that has to come from somewhere. And also how are we gonna basically pay for all these different treatments? Where is the funding going to come from? Is the insurance going to pay? Are they going to have to pay for it out of pocket? Or do we have to pass a law to help with all of that? So again, trying to figure out all these different things and all these developments that happened in the 50s through the 60s and 70s, with various laws that kind of helped towards that goal. Again, further in the 70s is when it kind of even moved to the next step. People started thinking again more and more about how do we get them back into the community? How do we give them back their quality of life, their function? How do we get them to be independent despite their limitations? It's possible the paralysis may only improve permanently to a certain extent because of the extent of the damage to their brain or the spinal cord. However, despite the limitation, how can we get them to be independent? People started thinking more about that, and they started creating residential programs to treat these individuals that way. They created outpatient programs to treat them to get to that ultimate goal. So that's when in the 70s is really when people started thinking more and more about that, and actually came up with act, not just, we could do this, you could do that, but at this point, they had enough, knowledge on what type of rehabilitation stuff that needs to be done, but there wasn't like a formalized program available to be able to do that. And this is when that all started, more formal programs. So basically further advancements. And also a lot of societies, brain injury, sort of IASTBI. IASTBI is basically an international association. I forget the exact acronym. I mean, acronym, what it actually is. But basically, it's a traumatic brain injury society, international society for traumatic brain injury that was being formed again to educate people who are interested, and people who are in this field of brain injury, kind of informing each other what's happening in the what are the developments, what's the research show, that kind of stuff, right? So, and then 80s and 90s, again, further advancement, mortality started falling down, better understanding of molecular mechanism with the brain injury. A lot more associations are now being formed. American and European Brain Injury Consortium journals are being published now in the field of brain injuries now. And again, more wars, more insurance changes, or more, I should say precisely more acts or laws that were being passed, and things of that nature, and also society, medical societies, getting again bigger and bigger because more people are interested in this field, and same thing. This slide also basically, again, just gives you more and more of that information. Again, developing in each of these things. Again, better understanding of the mechanisms, better care is being provided. Societies are getting bigger and better so they can kind of inform each other on the developments and implement these things when they treat their patients, and also to figure out what new research needs to be done. The programs continue to grow. So the field basically continues to get bigger and better, and etc. Again, we don't need to kind of go into the depth, but that you get the premise. At this point, it's basically like a snowballing effect, right? It starts with one and then just and I think the key thing with this is the key thing with this whole. So now we're starting to see a pattern. So the key thing with this is basically understanding the factors. Now we've kind of looked at these different things, different eras, starting from early 18th, 19th century, and we came all the way up to 21st century now. If we look at the pattern, if we can now, I'm sure most of you have kind of picked up at this point. Okay, there are certain things that are kind of leading the development. There are certain things that need to happen initially, which then leads to something else, then something else, then something else, and so forth and so on. This gives a better understanding, right? So this gave me a better understanding as to what are the factors that played a role, right? And if I'm interested in changing the direction the field is going, then I know what factors played a role, how much of an impact each of them had, which informs me what I would want to do. Either leave it as is, do something new, or use one of the old strategies, so forth and so on. And it's also interesting just to just learn it for the sake of learning, and for the fun of learning, kind of what happened, how it happened, things of that nature. So that's really my biggest take home. Really do know your history, so you can change the future. That's all I had. I'm gonna stop sharing my screen, and I think we did okay. We got 25 minutes for questions, so I think that should be plenty of time.
All right, thank you very much. All right, let me get a little bit organized here, and I've got some questions that we'll start off with. So the first question is, do neuropsychologists work closely with you? And if so, how do they work with you?
Sure. A lot of our individuals have a lot of the individuals that patients that I treat have brain injuries, and with brain injuries, they have cognitive deficits and mood deficits, meaning they have problem with memory, they have problem with thinking and focusing and remembering, so forth and so on. And a neuropsychologist, which Dr. Connor is going to go into more details, but a neuropsychologist is able to get an in-depth understanding as to what is the pattern of cognitive deficits that we're seeing, like what are their strengths and weaknesses in terms of their cognition, and if this is the pattern that we're seeing, what is the potential etiology? What is the potential cause? What's causing this? And also, is this truly a cognitive deficit, or is this because they have real bad depression and anxiety that if someone has real bad depression and anxiety, then they're not able to focus on what's happening, and which means they're going to have a hard time retaining information and recalling information, which may present as memory issues and mood, memory issues and thinking issues, but it might just be mood issues. Or if they have severe pain or severe headaches, then if you're in constant distress, you're not going to be able to focus and learn and retain things, so forth and so on. So understanding their cognitive issues in detail. Is it cognitive issue or not? If it's a cognitive issue, what is the pattern, and what is the reason that they have? Is it dementia? Is it just from the stroke, TBI, etc.? Now that's kind of the quick overview. Now, because of that, and we see a lot of individuals with brain injuries, and they often have these issues. We refer our patients for neuropsychological testing. And the neuropsychologists that are part of our practice, some of them are independent contractors, some of them are part-time employees, some of them are full-time employees. So we have various sort of model. They do our neuropsychological testing for these reasons that I just mentioned.
All righty, next question. I'm going to take this from the current chat. So it's almost a trick question. How many fields specifically in neurology exist? So I guess how many fields of medicine are impacted by neurology, and how many subsets within neurology exist is the way I tackle that.
Got it. How many fields in neurology? Okay. How many? Okay. Really, there are two sort of, you could think of it as kind of anything that deals with the nervous system. You can kind of think of it as two big categories. One is you're treating them with surgery, or you're treating them without surgery with medicines, injections, therapies. That's it. Those are the two, big categories. So you've got, and then the only people who perform surgeries are, well, I may be somewhat wrong in saying this, but the actual open brain surgeries, only neurosurgeons perform. Now, an radiologist or an interventional neuroradiologist can do a lot of interventional procedures to the brain. There are vascular surgeons who can also specialize in certain type of interventional procedures in the brain. there are neurologists now who also specialize in neurointerventional procedures, like interventional radiologists in performing certain interventional procedures in the brain, but not like open surgeries, but more minimally invasive procedures. They can put in a stent, or they can open up a blockage in the arteries in the neck, so forth and so on. So there's just a lot which I don't know if it's as relevant. Just but the simple way to think about it is, two big categories: either they do surgeries, or they don't do surgeries and they treat them with medicines, injections, therapies. Is kind of how you can kind of think about it, because there are so many kind of different subfields that you can kind of go into.
Right. Well, then, and I was thinking, I mean, you've got vascular neurology, child neurology, neuropsychology we've talked about, the neurodevelopmental disorders. There are a lot of ways to answer the question. And the other thing too is another big picture way to look at it would be to look at it by age groups and the prevalence of certain types of neurology practice by age group, which sort of leads to the next question. What demographic would you say you see more of in your practice?
So we treat anyone from 13 and above. I would say primarily between 20 to 40, 50 is probably the biggest demographic, I think. But I don't have data on what percentage and all that, but just purely based on observation, I suspect it's actually the 20 to 50 that I think we see the most. But we treat anywhere from 13 and above.
All righty. What is the average age that someone can become a neuropsychologist? How long would the medical training take after high school or college?
I'm going to pass that question to Dr. Connor, who will be presenting not the next presentation, but the presentation after. She's a neuropsychologist. She would be able to answer that question better.
Right. I think minimally probably 9 years, but what do I know? So interesting. This was a history question. What field specifically in rehab was of interest for people, the greatest interest for people during the 20th century? What was the predominant, what was the big one that really captured people's attention?
Would you mind repeating the question one more time for me, please?
What field in rehab was of greatest interest for people in the 20th century? It's a tough one.
I would say, let me put it this way. Just kind of, let me back up first. So rehab, you could either be a doctor and then do, go to med school, medical school, or DO school. You could do either, again, neurology, and then you can go into like neuro rehab, or you can do rehab and then go into various aspects, right? And then also, I think, those are probably the two big fields in terms of becoming a doctor and then going further in depth. And then the other, I would say, would be physical therapy or occupational therapy, or speech pathology, or I would say even chiropractic therapy would be considered rehabilitation in a lot of sense. So there's so many different kind of fields. Psychology, to a certain extent, you can call that rehab as well, because you're doing like counseling and rehabilitating, so forth and so on. So I would say, just just purely from that, I don't know, non-medical school fields, all the different other fields that we talked about, I would say physical therapy probably, just because the demand is a lot, and there are just a lot more physical therapists out there, compared to a lot of other specialties. I don't know the reasoning behind it. If just their society has just been very good and planning and things of that nature, or if it's more that there has just been demand and then they started to meet the demand. I'm not sure, but I would say, so most popular just purely in the sense that there are a lot more of them. But ultimately, it's not about what's popular, it's about what one wants, what
Mhm.
you want, right? That's what it's going to come down to, knowing what each field has to offer and how it's different and what you want.
Right. Well, so I'm 65 years old, and within my lifetime, I know one thing I have witnessed is that there was a time when you went and you got a hip replacement or a knee replacement, and you were simply recommended for bed rest. Of course, it's very different now. The whole approach has changed where you are up and walking right away. That's part of the impetus for having so many physical therapists and additional people right there. I think the other type of rehab that, from a public health perspective, and I know this is a little bit different, but addiction rehabilitation
Yep.
has certainly, I mean, it's not a shameful, it's a moral shortcoming. It's an addiction, it's a medical thing. So that's certainly grown. So someone asked here, what are opportunities and careers for physician assistants in this field?
Well, in this field, I would say they could, in the field of, rehabilitation, neurology, neurological rehab, I would say there is plenty. Primarily in the hospital setting than in the outpatient setting, but they do, I have seen them work in both settings, but there's good scope. Absolutely.
Right. And then the other part of this person's question, which I'm going to expand upon, is what about biotech? And I'm going to add genetics in this field. We all hear about CRISPR all the time, and gene editing. Anything happening with those disciplines in your field?
Um, I would say, with CRISPR, we don't even know how much difference we're going to be able to make in a good way. Like, it's something that we've just unlocked, something completely new. I'm sure that I should say I'm sure. Actually, I'm not aware of the latest developments in that sector region, how that's kind of impacting. But I will say, among brain injuries, particularly traumatic brain injuries, even more than stroke, traumatic brain injuries have gained a lot of traction, and absolutely, there is tons and tons and tons of research that's coming out every year. And I think it's also, from, concussions, right? Football, and they gained a lot of, sort of media, global attention, things of that nature. So definitely there's a lot of advance, but I'm not sure particularly about kind of the genetic aspect. But I do know that stem cells is something that have been studied, and so many other different options and technologies and treatments. are being. I mean the other one, right? Neuralink. Are you familiar with Neuralink, with Elon Musk's?
Oh, yeah.
Yeah, and I mean their goal, basically their objective is basically we want to be able to. They have like many goals, but they're kind of their immediate goal or their next step or their immediate next goal is we want to be able to cure pretty much brain and spinal cord injuries. That is their sort of their next immediate goal, and I'm sure they're studying a lot of new, innovative different treatments, etc. Um, which I'm not sure to the extent, currently what they're studying and all that, but so they're tackling this problem too. So yeah, there's definitely a lot of hope and a lot of amazing, interesting things happening for sure.
Right. Okay, what do you predict will happen in the future in regards to rehabilitation services? What's in your crystal ball?
No one has done it, but I do think that robotics. We do have. Let me put it this way. At least I would like to see. So the biggest problem in rehabilitation, particularly in neurological rehabilitation, is that what we do know is that after a brain-related condition, particularly if there's like a severe injuries, right, insult, injury, brain has the capability to, number one, heal by itself to a certain extent. Number two, we can help sort of form new connections, bring about new functions. But what we also do know is that the more repetition, more intense and more repetitive it is, the better these connections, the better the recording, the better the function. We've seen this repeatedly in multiple different studies. We know that that is true and accurate. So that's what the science and the research shows. Now, the issue is rehab is very manpower intensive field, meaning, to be able to do things as intensively as one could, when something is so manpower intensive, it also costs quite a bit, right? So if you're doing therapy 3, 4, 5, 6 hours a day, something like that, then which means you're going to have to again pay for their time, which is manpower intensive. It's quite expensive. And currently, insurances, including government insurance and private insurances, they pretty much they're the same in the sense they cover only so much, and that so much doesn't meet what if this is that so much, and this is what they may need. It doesn't meet it. It doesn't it's not on the same line, right? What they're able to pay is not even close to what one may need. And if somebody wants to even pay out of pocket, it's so expensive that it's not doable. I would like to see if the cost could significantly be lowered by innovation to the extent that it is not so expensive, so they can get these repetitions and intensity that they need to get much better recovery than what people are currently having. So I think one of the ways to be able to do that would be robotics. There are definitely a lot of regulations and things of that nature, but that's what I would like to see. Will it happen? How soon will it happen? Will the regulations things of that nature impede? Those are all possibilities, but that's what I would like to see. That is the biggest problem in rehab, but this is the biggest problem in neurological rehabilitation. We know what is needed, but we don't have the ability to do that and make it easily accessible.
Right. Well, and we also have science fiction, which can portray a very optimistic view of what we can do versus what we can really do right now.
Yeah.
We've only got time for 2 more questions, and I'm going to just sort of randomly pick 2 of these. So a short answer on this, if you can. Would you describe one case that kind of sums up how you help your patients from first visit to their final visit? That's a stopper, I'm sorry.
Let me put it this way. It's difficult to say because people have different, come with different conditions, different severity. Let's say, 20-year-old, they come in after a motor vehicle accident, nursing student, and they were in a bad car accident, and they had a bad brain injury, brain bleed. They were in coma. They, go through. They're in the hospital. They're in the inpatient rehab. After that, they come to see me afterwards. I see them in the clinic 2-3 months after their injury. After being in the hospital and rehab hospital and all that, and they're on quite a few medications that might or might not be helping, but they definitely needed it in the beginning. They also have quite a long ways to go. They were in school. The goal is to get them back to school, and basically looking at, okay, what are their deficits? Do they have speech issues? Do they have swallow issues? Do they have cognitive issues? Do they have paralysis, weakness in the arm and leg? Do they have vision issues? Do they have bowel issues, bladder issues? Kind of looking at them as a whole, and then coming up with a treatment plan, which includes therapies, medicines, cutting down on medicines or adding medicines, doing therapies, and then basically getting them back to where they were previously, so they can go back to, being a nursing student in school.
All righty, last question. And this is not necessarily about the topic, but perhaps a little bit more personal in nature. How do you or clinicians like you improve from past mistakes you make as a physician?
I think the primary thing is knowing that you're going to make a lot of mistakes. It's just given, and being open, being open to being accepting of yourself. It's okay if you do make mistakes, because it is possible, and also being open to change, and not being defensive. That's not because of me. I don't make a mistake. And really being sort of objective if you did make a mistake, and owning up to it, and recognizing that you made a mistake, and see why it was a mistake and what needs to be done to change it. So really being open to that fact, and also, again, being forgiving on yourself, I think, is also key, because it's very easy, because you're dealing with someone else's life. One small mistake could be, bad, and you might even make something like that. But as long as it's not an error of, um, morality, I think that's the crucial thing. Those things could happen. And you just, and if it does happen, it's okay to just.
Right. Well, doctor, thank you very, very much. Next week, I believe we're going to be with Justin Connor talking about broken bones and then some, life of a pediatric orthopedic surgeon. everybody, we'll see you next week. Thank you so much. Good night.
Bye.
Thank
Thanks,
you.
everybody.